So thanks very much, everyone, for the opportunity for Palliative Care Australia to contribute to this forum this afternoon. I think it's actually, when I was thinking about what to say here, it really made me reflect on. I've been working in cancer and palliative care for most of my nursing career for almost 30 years now, and I really have been. The last two speakers have reminded me that. While we have come a long way, I believe, in palliative care services and in the sector of end-of-life care, when I think about some of the things and some of the reasons I went into palliative care 25 years ago, there's actually some things that haven't changed and haven't moved on, and it's those sort of things that just listening to Stephen and sort of wanting to leave, one's contribution a little bit better. There are some things that I look at that were the reasons that I actually went into palliative care, which really haven't moved on very much at all. And those are the things that do worry me when we sort of when we come to forums like this, and we need to. And so I really want to acknowledge the idea and the concept of us sort of taking some time today on a public holiday to reflect and to think about innovations, because I am very much a believer that a lot of what we have been doing, while we've made great progress, some of the solutions that Stephen has just sort of suggested to us are really not going to come from doing the same things in the same way. So I think I thanks everyone for coming along on a Monday afternoon on a public holiday, because I'm hoping that there'll be some things which come from this which we may be able to really move forward. And Palliative Care Australia is really grateful for the opportunity to be part of this conversation. So I'm from the palliative care sector's point of view, just going to highlight just a few things. I'm not going to talk for very long, and some of the things which I think will probably be very obvious to most of you in the room, and really will complement what the speakers have said already today. I'm going to talk a little bit about the who is dying today and what is it that means for the sort of service provision and end-of-life care that we need to be looking for. And then just make a couple of comments about the type of service provision, service sector model we have in end-of-life care, as best that we understand it, because it is a little bit messy and a little bit unplanned, and I think therein lies some of the problem, and doesn't necessarily fit with those best practice principles that Stephen was talking about. So I'm just going to highlight some of those two things, and I'm also want to just make a couple of comments about what Palliative Care Australia is trying to do in some of its initiatives to try and, I suppose, look at how we can innovate within the sector. But I also acknowledge that everything I'm going to say here today is not necessarily Palliative Care Australia's view of the world. I'm including some of my own work as well, some of the work that I'm involved with, because I think it's pertinent to the conversation. So I think when and this has already been highlighted, that when we think about who needs palliative care today, I think it's obvious that it's actually not necessarily the sort of care that our health system is going to be able to respond to. I mean, there's been lots and lots written over a number of years now, which clearly recognises that the sort of people who are dying and the sort of nature of those trajectories of illness are very different to the sort of ways in which our healthcare system has been set up to respond to. And this was, way back in 2005 in the US, this Joanne Lynn and her work sort of pointing out that while one of the great successes of modern medicine has been to transform acute causes of death into chronic illnesses, that is the reality. But also Joanne Lynn's work reminds us, though, that while these are chronic illnesses, that the trajectories of dying remind us that we actually do need acute care at some points within that. It's not that chronic illness doesn't have acute exacerbations of illness that require acute interventions, and therein lies one of the challenges. It's not like a simple model of a straight pathway that we can plan, a predictable pathway for care. It's not like that at all. Rather, it's in fact the pathway for many people is one which is a long illness, which may have within it acute exacerbations, which do require immediate responses. And I said therein lies the problem for us in terms of coming up with solutions. It's not predictable often for us to manage. In Australia, what does that mean? Well, this is just the latest, the 2009 causes of death, and like we can go through all the lists. These are the top 5. But really, when we look at the causes of death in Australia, the top 20 causes of death account for 67.2% of deaths, and all but 3 of these, which were suicide, road deaths, and one other, I think, are associated with some sort of chronic condition. So it just reinforces that that's the nature of end-of-life care today, that we really do need to acknowledge that these are chronic illnesses. Care in the community, care in our health services are going to be over a length of time, and we need to have responsive processes both in the at the community level and at the healthcare service level to be able to deal with this challenge which we're talking about this afternoon. So that's the sort of who. But when in talking about that who, though, I suppose one of the things that that picture of the disease doesn't tell us, though, is the issue around what our community is like today. And when we're thinking about the sort of responses that we need to provide, while we can list causes of death and recognise that they're chronic illnesses, that biomedical point of view, we can try and understand that. What that doesn't highlight, though, is the difference in our communities that we have today that we didn't have 10 years ago, 20 years ago, in terms of more people living alone, more families which are not necessarily connected, more diverse cultural communities. And the implications of that for how we plan community care and healthcare services are profound, and things that I don't think that our system has really. We're flat out planning a healthcare system to deal with, a common trajectory from a biomedical disease, but we're certainly not very good at planning for that social diversity and the social differences. And the consequence of that, I think, I'm sad to say, really is I think one of the second challenges I'd like to highlight today, which is the variability in what people end up getting as part of their end-of-life care. I think one of the projects that I work on is a project called the Palliative Care Outcomes Collaboration. It's a quality improvement initiative that's around measuring outcomes of palliative care services, and once a year we get palliative care services in a room to benchmark. And I've just been at 2 benchmarking workshops on Thursday and Friday last week, our annual benchmarking. And one of the things we do is we go around the room first up, and we've got about 70 service providers in each benchmarking workshop, and we ask them to describe their service so that people can think in the room, is there like with like that you can benchmark with? And every time we do it, I'm absolutely struck by the difference in the room. There is no one service that is alike. And while one could say, well, that's beaut, that's innovative, that's people responding to local contexts, I also worry when you have that much variation, that what that means is that there's variation in the quality of what people are going to be getting. And it's because it's variation in terms of not just that the number of people I have in my service, but it's variation in terms of access to allied health, variation in terms of access to a general practitioner even sometimes. And I think those things are really significant messages for us in a healthcare system that prides itself on being one of the best in the world. So in terms of then, if we talked about the who and recognising that the chronic illness nature and the diversity of populations these days and communities and our need to respond to that, let's have just a little think about the what end of life care looks like. And as I said, one of the things, the first message is that great variation in what we call end of life care services today. And I think this edition of MJA is just a couple of weeks ago. This was published, and front cover, and it really highlights, it's very pertinent to the conversation today, isn't it? End of life care redefining what good care was about, because there were a couple of studies in this edition which I think told us a little bit about the last 12 months of life for a group in West Australia anyway, and I'm going to show just a little bit of the data from that work. But the editorial that went with this edition talked about that an aggressive, event-determined and hospital-centred model fails to give appropriate care to the terminally ill and older people who have complex chronic conditions. And the editor went on to sort of talk about that palliative care and aged care should not primarily be the province of the hospital and the acute healthcare system. And our continued acceptance of this and the concentration of healthcare spending in the last months of life is no longer tenable. It represents both bad care and a waste of money, was the editorial that was in the MJA when she was reflecting on a couple of the papers which were published in this edition. And I'm just going to highlight some data from one of those papers, and this was for some work which is done by Lorna Rosenwax and her group in West Australia. where what she did was looked at, they have a lot of linked data systems in WA, and so she was able to look at a retrospective study where they looked at death registrations and morbidity data for over 1,000 West Australians who died in almost a 12-month period. And she had some categories, but mostly what she was looking at were those people, I suppose, who would have had a predictable death in terms of what she was looking for. But what her findings were, so this is really what she did. She looked at this linked data, and I think, again, this has really important implications when we're trying to understand what end-of-life care is in our world today, in Australia today. What she found that all but 4% spent time in hospital, and that increased over the last 108 days of life for people with cancer and the last 83 days of life for people with non-cancer conditions. She also identified that those with cancer spent less time in hospital than those with other diagnoses, which again I think has really important implications too for where we're putting our community services. 70% had at least one emergency presentation, and that's extraordinary, isn't it, when you think about the waste which Stephen was sort of talking about. And on the last day of life, 61.5% were in hospital and 4% had been seen in an emergency department on their last day of life. So this data is, for representative sort of population in WA is extraordinary. And this is where it's getting that balance right, isn't it, between, as I said, this wanting the best possible sort of care for people in our community, getting that best medical care balanced with social care and what people really need and want. And I think fundamental to that, and that's where it's very difficult to stand back and say that there's one right approach, because fundamental to that is the issue about choice. But when you start talking about choice around people's preferred place of death and those sorts of things, that then gets complicated with the whole notion of how truly informed people are around some of the options that are available to them, and do they only see that turning up to an emergency department is the only option to them that's even presented to them, for example, as I think what you were saying, Debbie, is a whole range of issues and questions which I can't give you the answer to today, but questions which I think data like this raises. I also just wanted to show, and this is not Palliative Care Australia data, this is, and you're not meant to sort of understand what all the slides are. I'm using this just to sort of highlight one of the issues. This is our Palliative Care Outcomes project when I look at these graphs, the message that this graph is showing us, these across the bottom are different services. Those numbers are different palliative care services in Australia. And one of the benchmark measures we use with palliative care services with Peacock is the time from referral to a service to the time to first contact. And the sector has agreed on a benchmark of within 48 hours. From the time you're referred, you should be seen within 48 hours. What these slides, these services across the bottom, are the extent to which the services are actually meeting that benchmark. So the point here I want to sort of say is we've got a service down here which can't meet the benchmark, isn't meeting the benchmark in 20% of occasions, whereas some services meeting it at 100% of occasions. Now, it doesn't really matter what those services are. The point is the issue about variation in quality of care. If we can have some people who can be in a service that 100% will see you within 48 hours, but other services where it's less than 20%, I think we have a problem with that needs really some processes to really look at how we can develop innovative solutions. Because it's not that these services are bad, it's oftentimes associated with the models of care or the lack of resources or lack of something that needs to be addressed if we are going to improve. And when we look at this variation, it's not just about in terms of time to referral and being seen. It's actually also variation in some of the clinical benchmarks that we use. So this is a benchmark which is really assessing when patients are in an unstable phase. One would think if you're referred, an unstable phase is like an emergent situation is how we define it. So something that needs to be, so someone has an unstable pain situation that needs to be got on top of straight away. This is the benchmark which the sector set, was that we should be able to see that a reasonable number of patients should be able to have that unstable phase dealt with within 7 days. And again, the point is here about the variation. We've got some services who aren't able to achieve that benchmark for various reasons, and other services who are. So in terms of innovation, I think one of the things that is a potential for us to think about is what can we learn from those services up there that are able to do it, and what is it that they have access to, what is it that actually makes up the sort of care model that maybe we might need to think about in terms of innovation in the future, because we do clearly have some services that are doing very well. And I think I'll just sort of one of the other points from our data that I wanted to make as well is we've got the variation in care, and what I suppose the context, and so the other issue that I was asked to talk a little bit about in terms of the context of Palliative Care Australia and what we have, the National Palliative Care Strategy is really, what potential does that provide us in terms of thinking about innovations. Well, they just released the new National Palliative Care Strategy towards the end of last year, and I think that it says all the right things that do provide us some opportunities to really think about where we can implement innovations to achieve the sorts of things that people in this room, I think, are aspiring to. It's got strategies which are relate around awareness and understanding, and it talks about its particular actions within that are about significantly improving the appreciation of dying and death as a normal part of the life continuum. It talks about enhancing community and professional awareness of the scope and benefits of timely and appropriate access to palliative care services. It also talks about appropriateness and effectiveness of care, and that it's available to all people on the basis of needs. So I think that some of the issues and some of those areas in the national and the policy framework provide us with some potential to develop programs that fit within the sort of government strategy. They also talk about, though, I think really other key things in this strategy, if we're going to achieve this, though, is the need for better leadership and governance and around palliative care, and that whole notion of that variation that we have in the way services are developed, variation in funding and variation in outcomes. Part of what's going to need to address that is some of the leadership and governance which needs to be put in place so that we can reduce some of those outcomes. And certainly capacity and capability, and it talks there about all relevant sectors in the health and human services, which I think is some of the key points that have already been made by speakers today. So the policy framework, I think, is right. It's recognising that we do need to move forward and address some of these sorts of issues. But what the challenge for us here today, though, in talking about how we're going to move ahead with thinking about innovations, means that it is going to be across all sectors. I think it is going to be around the community sector, it is going to be within the specialist sector, it is going to be within the primary healthcare sector. A couple of things Palliative Care Australia are doing to try and, I suppose, contribute to innovation and to try and achieve some of those goals. And I think one of the most important initiatives that Palliative Care Australia has done over the last 3 years is its National Standards Assessment Project. That project is where they are getting, where palliative care services can voluntarily enrol and assess themselves against the standards that have been set by the sector. And on the basis of that assessment, they get a report, and they can also voluntarily engage in a peer review process. And some projects which have resulted from that have really led to local innovation. But more recently, one of the initiatives which this National Standards Assessment Project is moving forward with is developing communities of practice, where they have got palliative care providers around. One of the key problem areas which people identified was simply care planning, actually. Simply the difficulty it was in terms of setting care plans that were integrated with, which brought in all of the different components of care that are needed for that complex part of a patient's journey. And the communities of practice have been set up where people are voluntarily coming along to try and look at how we can share different ways of actually making that care planning process more efficient and more integrated, and is starting to achieve really good outcomes in that way. So that's one of the examples of how Palliative Care Australia is trying to work within the sector to achieve some of those sorts of innovative solutions from within. And I think the other thing that Palliative Care Australia does quite well, and with its community awareness and its National Palliative Care Week, which we've just had recently. And it's in each year I see it getting more and more traction, and each year, and we talk about the difficulty our community has with dying. Each year of my involvement with palliative care, I've seen it get more and more public in terms of its contribution and awareness within the community. And this year in particular, it did manage to get a lot of media attention, and just simply around the theme for the week was something around, was just let's have a chat about dying. And in some simple ways, those sorts of things to try and change our comfort and our ability as a community to engage in conversations is going to be a really critical start to thinking about innovation.
Okay, thank you. Thanks so much.